morning to all of you. Thank you, Dr. Dinesh sir, for the kind words. So I'll be talking about the applications of anterior segment OCT. And before I proceed, just a brief about the existing AIOCT systems. There are two types of systems. One is dedicated systems that use the wavelength of 13 and 110 nanometers and provide us with deeper and wider scans. And then there are systems converted from the retinal scanners where the wavelength used is 830 nanometers. The resolution is very high, but the scans are shorter in length. The systems that are converted from retinal scanners, we need to use certain adapter lenses for the various scan options. And this is how you visualize the cornea. Almost all the layers are clearly visible on the AIOCT. Now coming on to the clinical applications, the one main application is used in keratoconus. So you can diagnose keratoconus based upon certain criteria in the central pachymetry map. And this is how the keratoconus looks like on AIOCT, and you even have the progression maps if you want to look for the progression. And epithelial mapping is a newer concept which is based upon the observation that the epithelium compensates for the stromal surface irregularities. And we see it as inferior thinning corresponding to the thinnest cornea. It is very useful in detection of the early keratoconus, PMCD, or detection of the early ectasia. Now, even before the epithelium is involved, there is disintegration of the Bowman's membrane, which can be seen as localized relative inferior thinning on the spectral domain OCT. Now, this is a case of acute hydrops, where you can see that the corneal edema has subsided, but you can still see the breaks in the Descemet's membrane with rolled over margins. So, in cases of advanced keratoconus or acute hydrops, you can monitor the response to treatment by doing repeated serial AIOCTs. And this is how the demarcation line post-corneal collagen cross-linking looks like on AIOCT. This is a direct clinical indicator of efficacy of CXL. So one can see this line after a month of the therapy. Ultra-high resolution OCT can even visualize the intracorneal ring segments very clearly. And you can see if there is any stromal thinning, overlying stromal melt, or early extrusion of the intacs. All these things can help us clinically to manage the patients. Now, in a patient where there is a corneal scar, we need to know the depth of the scar to manage it properly. For example, this is a patient who underwent microkeratome assisted LASIK surgery somewhere else. You can see a big scar in the visual axis. So now this patient had a refraction of -2 diaspherical with lot of night vision issues, glare, halos, poor quality of vision. So before we proceed for any kind of treatment, we need to know the depth of the scar. So as AIOCT shows, the scar was involving almost the whole extent of the flap, but there was sufficient residual stromal thickness. So we decided first to amputate the flap, and this is how the cornea looks like after a month of the surgery, and the patient had significant improvement in the symptoms, but the post-op refraction was around -2 diaslender. So the patient didn't want any other surgery after that. You can even visualize the LASIK flap through and through with AIOCT, and it can visualize the flap even after years of refractive surgery. So if you want to redo surgery, it's very, very important to do the AIOCT to know the flap thickness. For example, in this patient, the patient has a residual refractive error of -1.75 diopters. The patient underwent LASIK surgery years back, and we didn't know what to do, whether to relift the flap or do the surface ablation. So the AIOCT showed that the residual stromal bed was just 265 microns. So it's not advisable to relift the flap in these cases, so we proceeded with the surface ablation. So here is an interesting case of epithelial ingrowth, which looks like this milky fluid in the periphery. And now in this patient, either we can observe the patient or we can remove the epithelial ingrowth. But if you do AIOCT, the extent of the epithelial ingrowth is much wider, and there was overlying flap melting or thinning. So we decided to remove the epithelial ingrowth. And similarly, this is another patient in which you can see scattered epithelial nests throughout, but post-removal, the cornea was clear. So you can monitor the response to the therapy after by doing AIOCTs. Now it's very important to know the health of the dissect graft for the corneal surgeons. As you can see in this OCT, the graft is very well, nicely attached post-surgery. But there is another patient in which there is a central detachment of the graft. Sometimes on the slit lamp it's not possible to visualize because of the corneal edema if there is graft detachment. So in this particular patient, rebubbling was done, and you can see that post rebubbling the graft is very well attached with the absorption of the corneal edema. Now, in 14% of the patients, it's not possible to detect the DM detachment on slit lamp examination. They are missed DM detachments. But when you do AIOCT, even in corneal edema, you can very clearly visualize the descending membrane detachment. And in this particular patient, we just injected the air, and within 24 hours, there was resolution of the corneal edema with reattachment of the DM. Now, all these pictures that I had shown earlier was taken on the retinal, the systems converted from the retinal scanners. Now, this one is a dedicated anterior segment OCT system, Anterior. You can visualize almost whole of the anterior segment. It's beautifully shown, a very nicely shown subluxated cataract with a tilt and irregular anterior chamber depth. Again, this picture is on Anterior. This was a patient of uveitis with a membrane formation on the IOL, and that caused posterior synecdoche and pupillary block. So these tools are not only there to improve our diagnostic ability, but also for research and teaching purpose. Again, this is a picture taken on the Anterior, in which the patient had secondary glaucoma post-uveitis, and the inflammatory reaction, which was mixed like AC cells plus pigment. You can visualize that very clearly, and we can monitor the response to the treatment also on AIOCT. Now, the most recent advancement in the cataract surgery is femtolaser assisted cataract surgery. All the systems, they have real-time OCT integrated in it. So we can visualize the whole of the anterior segment, and especially useful in the posterior polar cataract, where you can see the pre-existing PC defect just before doing the laser treatment, and you can just reduce the area of lens fragmentation to leave an epinuclear cushion behind. Now, intraoperative OCT is a newer concept. We are still exploring the applications. But in this patient, it had a PCR, and here you can see that there's a vitreous mount that is prolapsing through the PCR. So you can visualize these things and manage the case in a better way. Another important application is to know the vault size of the ICL. Vault is the distance between the posterior surface of the ICL and anterior surface of the lens. So the normal range of the vault is somewhere around 250 to 750 microns. A very low vault, as seen in this AIOCT image, can lead to the cataract formation. And if the vault is very high, it can lead to the increase in intraocular pressure. Now, this patient had inverted ICL. So the surgeon didn't realize when saw the patient on day 1, and we saw, they confirmed that thing on the AIOCT, and we had to take the patient again in OT explant and re-implant the same ICL. So there are a lot of other indications like tear film, meniscus measurements, IOL power calculations, and in infective keratitis also it's very useful. So it's not possible to cover all the indications, applications in one go. So AIOCT, I feel, is a versatile, non-invasive tool for pre- and post-operative assessment of the cornea and refractive surgery patients. And newer technologies such as ultra-high resolution OCT and intraoperative OCT can improve our ability to diagnose and treat corneal disorders in a better way. Thank you. Thank you so much for the patient listening.
Thank you, Hemlata.